A patient presents with bleeding and a positive pregnancy test. In the first trimester, this clinical picture points to a turbulent environment inside a hidden biological space. Symptoms alone offer zero definitive answers. When an early ultrasound is performed, the sonographer has a strict mandate. They must systematically evaluate the anatomy to rule in an intrauterine pregnancy, confirm its viability, or explicitly categorize the exact mode of failure. Every sonographic reference relies on a single foundational dating metric, menstrual age. This is the baseline from which all normal development and abnormal deviations are measured. Menstrual age is calculated by taking the true embryological age and adding exactly 14 days. This timeline establishes the critical terminology. From 0 to 10 weeks menstrual age, the developing organism is an embryo. Beyond 10 weeks, it is a fetus. Adhering strictly to this dating baseline allows clinicians to standardize highly subjective sonographic findings. Using objective metrics is the only way to prevent the catastrophic error of intervening in and terminating a normal, viable pregnancy. When an early pregnancy fails, the clinical vocabulary used to describe the abortion is rigid. The precise diagnosis depends on two physical factors: the dilation state of the cervix and the presence or absence of retained tissue. A threatened abortion features clinical bleeding, but the cervix remains strictly closed. An inevitable abortion shows cervical dilation with tissue protruding through the canal. If residual products remain trapped, it's an incomplete abortion. If entirely empty, it's a complete abortion. In a missed abortion, the fetus has died, but the cervix remains entirely closed, keeping the deceased fetus contained within the uterus. Accurately classifying the physical state of the cervix and cavity directly dictates the next step. It tells the clinician whether the patient requires expectant management, medication to clear the cavity, or urgent surgical intervention. A normal early gestation does not appear at random. It follows a predictable chronological sequence of sonographic milestones. The first reliable sign of an intrauterine pregnancy is the early gestational sac. Under optimal conditions, this becomes visible at approximately 4.5 weeks menstrual age. To confirm this is a true gestational sac and not just free fluid pooling in the canal, you must track the thin, bright echogenic line of the uterine cavity. That line must pass by the sac, proving it is deeply implanted in the tissue. Visualizing the two distinct layers of the decidua creates the double decidua sac sign. Finding this double ring is a highly characteristic, positive indicator of early pregnancy. Within the chorionic cavity, the yolk sac eventually appears. A normal yolk sac must measure between 3 and 6 millimeters. It must be a simple, fluid-filled circle, never solid and never calcified. Anatomically, this yolk sac serves as the early life support system, hooking directly up to the embryo's umbilicus via the vitelline duct. This structural relationship creates the double bleb sign, which is the earliest possible visualization of the embryo itself. You are looking at the yolk sac and the amniotic sac, with a flat embryo sandwiched exactly in the middle. Successfully documenting this anatomical sequence proves the pregnancy is tracking normally. It establishes a baseline of viability well before fetal cardiac activity can be detected on a monitor. During this early development, the membranes of the amniotic sac and the surrounding chorionic space do not touch. They remain separated by a thin protective layer of fluid. Normal fusion of these two membranes occurs much later in the pregnancy, typically between 14 and 16 weeks. If the inner amniotic membrane is prematurely disrupted before 10 weeks, it triggers a severe pathology known as amniotic band syndrome. When that barrier breaks, the fetus can cross outward into the chorionic cavity. There, it becomes tangled in sticky, fibrous bands of tissue. As the fetus grows, these bands act as tourniquets, leading to severe physical trauma like limb amputation or even decapitation. Measuring the embryo is standard practice, but evaluating the structural integrity of these microscopic early membranes is just as vital to fetal survival. When the sequence of viability breaks down, clinicians look for specific markers of failure. One common complication is a subchorionic hemorrhage, a physical detachment of the chorion from the underlying endometrium. The scale of the detachment dictates the prognosis. If the resulting hematoma covers greater than 2/3 of the chorion's circumference, the patient faces a twofold increased risk of abortion. Beyond hemorrhage, the shape and contents of the sac provide immediate red flags. A large sac measuring greater than 8 to 10 millimeters that entirely lacks a yolk sac, especially if it presents with a distorted, irregular contour, heavily indicates a non-viable pregnancy. This table outlines the absolute biometric cutoffs used to diagnose pregnancy failure. The first definitive rule: a crown rump length greater than 7 millimeters with no detectable heartbeat. The definitive threshold for the sac itself: a mean sac diameter of greater than 25 millimeters with no embryo visible inside. Failure is also diagnosed through strict time-lapse observations. If a scan shows a gestational sac with a yolk sac, and 11 days later there is still no embryo with a heartbeat, the pregnancy has failed. If the initial scan showed only a sac, that window extends to 14 days. These numbers are not guidelines, they are non-negotiable binary markers. They were designed specifically to absolutely prevent a clinician from terminating a viable pregnancy that is simply developing slower than expected. A distinct clinical challenge arises with a pregnancy of unknown location, or PUL. The patient has positive pregnancy hormones, but ultrasound reveals neither a normal intrauterine pregnancy nor an ectopic mass. By the time beta-HCG levels reach the discriminatory zone of 1,500 to 2,000 milli-international units per milliliter, a true gestational sac should be visible in the uterus. If nothing is visible at those hormone levels, the differential diagnosis narrows to 3 distinct possibilities: a normal but very early pregnancy, an occult ectopic pregnancy, or a complete miscarriage that has already passed. Navigating a PUL comes with a major diagnostic pitfall: confusing a pseudo-gestational sac for a true early intrauterine pregnancy. This split-screen comparison shows the difference. A pseudo-gestational sac is not a pregnancy at all. It is simply a small collection of blood in the uterine cavity, surrounded by a bright single layer of decidual endometrium that has been artificially charged up by ectopic pregnancy hormones. Notice the distinct lack of the double decidual ring. Misinterpreting this hormonally driven blood collection as a viable early pregnancy gives the clinician a false sense of security. It stops the search for an ectopic, directly delaying life-saving intervention. When an ectopic is present, its anatomical location dictates the immediate risk. Nearly 95% of all ectopic pregnancies occur within the fallopian tube, most commonly settling in the ampulla. Approximately 2% of ectopic cases occur in the interstitial segment. These are incredibly rare, but carry an extreme level of danger. Because interstitial ectopics develop in the portion of the tube passing directly through the thick uterine wall, the surrounding muscle allows them to grow much larger before finally tearing. When they do rupture, they cause a catastrophic, life-threatening hemorrhage. To find these hidden threats, sonographers rely on a specific visual marker. The gold standard for identifying an adnexal mass as an ectopic is the tubal ring sign. The tubal ring is a thick, bright echogenic circle that completely surrounds an unruptured ectopic pregnancy. Finding this ring outside the uterus is highly accurate, carrying a 95% specificity for ectopic diagnosis. Pinpointing the exact anatomical location of this ring determines exactly what happens next. It separates a routine ectopic intervention from an impending, massive hemorrhagic emergency. Often, an exact embryo or clear tubal ring isn't perfectly visible. In these ambiguous cases, clinicians rely on a probabilistic matrix to calculate the positive predictive value, or PPV, of an ectopic. The first baseline rule: finding an empty uterus combined with any adnexal mass, other than a standard corpus luteum cyst, yields a 75% to 85% positive predictive value for ectopic pregnancy. The risk escalates rapidly based on surrounding fluid. If an empty uterus, an adnexal mass, and a moderate volume of free fluid are all present together, the probability of an ectopic jumps to 97%. That risk is even higher if the fluid is echogenic, suggesting active bleeding. Clinicians must also account for a heterotopic pregnancy, a rare scenario where a viable baby exists in the uterus, while a separate ectopic mass develops in the tube. This is primarily seen in patients with a history of severe pelvic inflammatory disease or those undergoing ovulation induction. If a patient is stable but their pregnancy location remains unknown, the management protocol relies on time. The patient is scheduled for a repeat ultrasound, while their beta-HCG levels are tracked serially. A normal hormone doubling time makes an ectopic significantly less likely. First trimester triage requires continuous, rigorous risk stratification. Clinicians use these strict numerical cutoffs and sonographic signs to execute a precise balancing act, protecting a vulnerable, early viable pregnancy while neutralizing the lethal hidden threat of ectopic rupture.